Hello everyone, welcome to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Ghayed and Maya, your host for today's episode, and I'm joined by the one and only Maya Ibrahim.
Thanks, Ghayed. I'm so excited to be here. We've got a lot to unpack today, from basic spinal cord anatomy to the complex yet fascinating tracts and lesions.
Okay then, let's not waste any more time. Why don't you start by giving us an overview of the location of the spinal cord and its protective structures?
Of course, the spinal cord is a cylindrical structure that runs all the way from the foramen magnum in the skull to about the L1, L2 vertebra in adults and the L2, L3 in infants.
Got it. And is there a specific reason we make that distinction between adults and infants?
Yes, actually. It's a very important distinction clinically because it guides us on where we can safely obtain cerebrospinal fluid from a lumbar puncture. We have to be very careful to avoid the spinal cord to not cause injury to it.
Okay, that makes sense. Then I assume we'd go one level lower than the spinal cord to avoid it. So for adults, we'd go in at L3, L4, and for infants, L4, L5?
Exactly. You catch on pretty fast.
Thanks. I can tell that protecting the spinal cord is a major focus for clinicians. Are there any structures surrounding it that protect it?
Of course, it's protected by the vertebral column, 3 layers of meninges, and the cerebrospinal fluid.
That's a relief. And what about the vertebral segments and nerves?
So, regarding the vertebral column, the spinal cord has 31 segments, each giving rise to a pair of spinal nerves that exit through the intervertebral foramina. It also has 2 key enlargements, the cervical and the lumbosacral, that supply the limbs. And let's not forget the cauda equina, the bundle of nerve roots extending below the conus medullaris.
Fascinating. I think we're ready to get into all the tracts and lesions now.
Okay, I know you're excited, but we're going to take it step by step for our listeners.
Okay. So we know the spinal cord is composed of gray and white matter. But what does that even mean?
Oh yeah, the spinal cord is divided into the gray matter and the white matter. The gray matter, shaped like a butterfly, is where we find the cell bodies of our neurons. It's organized into 3 regions: the anterior horn, which are our motor neurons, the posterior horn, which are sensory neurons, and the lateral horn, which is located in the thoracolumbar region and contains the preganglionic sympathetic neurons.
Okay, got it. So it has the anterior, posterior, and lateral horns. What about the white matter?
The white matter surrounds the gray matter, and it contains the ascending sensory and the descending motor tracts. It's divided into the anterior, lateral, and posterior white columns, each carrying specific types of information.
Okay, so this brings us to the tracts themselves, which are like highways for information. Let's break them down one by one.
Sure, let's start with the ascending tracts. We have 3 tracts that carry sensory information. These include the dorsal column medial lemniscus pathway, the spinothalamic tract, and the spinocerebellar tracts.
Okay then, Maya. Let's get started with the first tract, the dorsal column.
The dorsal column carries 3 main sensations: vibration, two-touch discrimination, and conscious proprioception. Keep those in mind for when we discuss the lesions. Oh, and speaking of, you may also want to remember that it decussates at the medulla, a region of the brainstem.
Wait, what does that mean?
Well, as these tracts ascend the spinal cord, each one crosses over to the other side at a different point. Some of them cross over while they're still at the spinal cord, while others cross over when they're past the spinal cord in the brain.
And what would that tell us?
This will help us locate where a lesion is based on the presentation of the patient. So if I told you that someone lost their vibration, two-touch discrimination, and conscious proprioception senses on the right side of their body, below the umbilicus, you know that the right dorsal column tract must have been affected.
Okay, I think I got it. So if the loss of sensation had been somewhere above the brainstem on the right side, that would mean the left dorsal column tract was affected, right?
Yes, exactly. It may seem complicated at first, but you'll get the hang of it.
Okay, let's discuss the spinothalamic tract now. What sensations does it carry and where does it decussate?
The spinothalamic tract handles pain, temperature, crude touch, and pressure. It decussates within the spinal cord.
Got it. And the last one?
Finally, we have the spinocerebellar tract. This one's responsible for unconscious proprioception. In this tract, some fibers remain ipsilateral while others cross.
Alright, now to the descending tracts.
Okay, this one's much easier. The key descending tract is the corticospinal tract, responsible for voluntary motor control. Most fibers decussate in the medulla to form the lateral corticospinal tract, while a smaller portion forms the anterior corticospinal tract, and decussates at the spinal cord level of innervation.
Now, on to the main event, our disease discussions. Maya, what's the case we're starting with?
Let's start with a 7-month-old infant who presents with poor muscle tone, difficulty feeding, and a weak cry. On examination, you notice a flaccid paralysis and tongue fasciculations. What do you think is going on here, Ghayed?
Oh, that sounds concerning. Could this be spinal muscular atrophy?
Exactly! SMA is an autosomal recessive disorder caused by a mutation in the SMN1 gene that leads to degeneration of the motor neurons in the anterior gray horn of the spinal cord. It causes progressive muscle weakness and atrophy, often starting in infancy.
Oh, wait. Is that why they're referred to as floppy babies?
Yup!
Okay, so we have a mutation in the SMN1 gene causing symmetric weakness, hypotonia, and tongue fasciculations. But how do we diagnose SMA?
Key findings include flaccid paralysis, tongue fasciculations, and hypotonia. Diagnosis is confirmed with genetic testing to detect the SMN1 mutation that is crucial for motor neuron survival.
Okay, Maya, what's our next case?
Now picture this. A 60-year-old man presents with progressive weakness in his hands, frequent muscle cramps, and slurred speech. On examination, there's muscle atrophy, spasticity, and hyperreflexia, but no sensory defects. What do you think, Ghayed?
I think it sounds like ALS, but can you confirm?
Correct. ALS, or amyotrophic lateral sclerosis, is a neurodegenerative disease that affects both the upper and lower motor neurons, leading to progressive muscle weakness and atrophy. About 10% of the cases are familial, linked to mutations like SOD1, while the rest are sporadic. Environmental factors like toxin exposure may also play a role.
So, what's happening to the nervous system?
Upper motor neuron degeneration leads to spasticity and hyperreflexia, while lower motor neuron loss causes atrophy, fasciculations, and weakness.
So, how is ALS diagnosed?
Using EMG to detect deinnervation and an MRI to rule out mimicking conditions. Sensory pathways are unaffected, which is a key clue.
So, here's your question. Which pathways are affected in ALS?
That would be motor neurons. On to the next case. Imagine a 50-year-old man presenting with unsteady gait, stabbing pain in his legs, and a positive Romberg test. He also has diminished vibration sense and an Argo-Robinson pupil. What's your guess, Ghayed?
Could this be Tapes dorsalis?
Exactly. Tapes dorsalis is a late complication of untreated syphilis, causing degeneration of the dorsal columns and the dorsal roots, leading to sensory ataxia and pain.
But what causes it? Does it only happen in syphilis?
Yes, it's specific to syphilis caused by Treponema pallidum. It usually appears decades after the primary infection if left untreated.
Okay, on to our next case.
A 65-year-old woman presents with progressive numbness and tingling in her feet, difficulty walking, and fatigue. She mentions being a strict vegetarian. On examination, she has decreased vibration sense, hyperreflexia, and a positive Romberg sign. What do you think?
Sounds like there's an issue with her nervous system and maybe her diet. Could this be vitamin B12 deficiency?
Yes, this condition leads to subacute combined degeneration of the spinal cord, affecting the dorsal columns, cortical spinal tracts, and the spinocerebellar tracts, causing sensory and motor dysfunction.
And what are the most common causes?
Common causes include pernicious anemia, gastrectomy, chronic alcohol abuse, and strict vegetarian diets without supplementation.
And how do we confirm the diagnosis?
Blood tests show low B12 levels and elevated methylmalonic acid and homocysteine, which confirms a functional B12 deficiency.
But is the damage reversible?
Yes, but only if caught early. Treatment includes intramuscular B12 injections or oral supplementation.
On to our next case.
A 45-year-old man presents to the ER with severe lower back pain, numbness in the inner thighs, and difficulty urinating. He also reports weakness in his legs. What do you think, Ghayed?
Interesting. That sounds like an emergency. Could this be Ghayed-Maya syndrome?
Exactly. Ghayed-Maya syndrome is a surgical emergency caused by the compression of the cauda nerve roots, leading to severe neurological impairment.
And what are the most common causes?
The biggest culprits are massive herniated discs, trauma, tumors, or epidural abscesses, compressing the nerve roots.
What are the hallmark signs?
The compression disrupts motor and sensory function, and the key findings include saddle anesthesia, loss of bowel or bladder control, and reduced reflexes. Diagnosis is confirmed with an urgent MRI.
Okay, so here's a question. What is the most urgent next step in suspected Ghayed-Maya syndrome?
The answer is urgent MRI, the gold standard for diagnosis.
Got it. What's our next case?
A 5-year-old child from an under-vaccinated community develops sudden onset weakness in one leg. They have fever, headache, and difficulty walking. On exam, there is an asymmetric flaccid paralysis with absent reflexes. What's your diagnosis, Ghayed?
Could this be Poliomyelitis?
Yes, poliomyelitis is a viral infection that targets the anterior gray horn cells of the spinal cord, leading to flaccid paralysis.
And how is it transmitted?
It spreads via the fecal-oral route, commonly through contaminated food or water. Think of how little kids always put things in their mouth, and it'll be easy to remember the mode of transmission and how it's more commonly seen in kids.
That's a nice way to remember it. So, how do we confirm the diagnosis?
CSF analysis shows elevated white blood cells and protein with normal glucose. Viral PCR can confirm poliovirus.
And how do we treat it?
There's no cure, just supportive care like physical therapy. Prevention with polio vaccine is the best approach.
Okay, here's a question. Which part of the nervous system is primarily affected in poliomyelitis?
The answer is anterior horn cells, leading to flaccid paralysis.
Okay, what's our next case?
A 15-year-old boy presents with progressive difficulty walking, frequent falls, and slurred speech. His family mentions a history of similar symptoms in a relative. On examination, he has gait ataxia, dysarthria, and loss of deep tendon reflexes. What's going on here, Ghayed?
So a young patient with progressive ataxia and family history, could this be Friedreich's ataxia?
Exactly. Friedreich's ataxia is an autosomal recessive neurodegenerative disease caused by a GAA trinucleotide repeat expansion in the FXN gene, leading to progressive ataxia and weakness.
Okay, so it's genetic. What does the FXN gene do?
It encodes for frataxin, a mitochondrial protein essential for iron homeostasis. Its deficiency leads to mitochondrial dysfunction and neural degeneration.
And what's happening in the nervous system?
The spinocerebellar tracts, corticospinal tracts, and dorsal columns degenerate, leading to ataxia, spasticity, and impaired proprioception.
Oh, okay. And is there a cure?
Unfortunately, no. Treatment is supportive, physical therapy, and managing complications like cardiomyopathy and diabetes.
Okay, on to our next case.
A 30-year-old man is brought to the ER after being stabbed in the back. He has loss of pain, temperature sensation on one side of his body, and weakness and loss of proprioception on the opposite side.
That sounds like a classic spinal cord hemisection. So could this be Brown-Séquard Syndrome?
Exactly. Brown-Séquard Syndrome occurs when one side of the spinal cord is injured, causing ipsilateral motor and proprioception loss and contralateral pain and temperature loss.
What usually causes this?
Trauma such as stab wounds, gunshot injuries, or spinal tumors.
And why do we see these opposite-sided symptoms?
Because the corticospinal and the dorsal column pathways cross at the medulla, so injury to one side causes ipsilateral weakness and proprioception loss. Meanwhile, the spinothalamic tract crosses at the spinal cord level, leading to contralateral pain and temperature loss.
Okay, and how do you diagnose it?
Clinical examination is key. MRI can confirm spinal cord injury.
Okay, I have a question for you. In Brown-Séquard syndrome, which functions are lost on the same side as the injury?
The answer is motor function, corticospinal, and proprioception, dorsal column.
Okay, and what's our next case?
An elderly man falls forward on his face. He now has weakness in his arms, but his legs are less affected.
This sounds like central cord syndrome, right?
Yes, central cord syndrome is caused by damage to the central portion of the spinal cord, affecting upper limbs more than the lower limbs.
And what are the common causes?
Hyperextension injuries in older adults with cervical spondylosis.
So why do the arms get affected more than the legs?
The corticospinal tract is somatotopically arranged. The arm fibers are more central, so central cord injury affects them more than the legs.
Got it. So what's our next case?
A 35-year-old man presents with progressive weakness in his hands and a loss of pain and temperature sensation in a cape-like distribution over his shoulders and upper arms. However, touch and proprioception are intact.
That sensory loss pattern sounds specific. Could this be Syringomyelia?
Exactly. Syringomyelia is a condition where a fluid-filled cyst forms within the spinal cord, usually in the cervical region, disrupting specific neural pathways.
And what causes it?
It's most commonly associated with Chiari malformation type 1, but it can also be caused by spinal cord trauma, tumors, or meningitis.
So why do we see this strange sensory loss pattern?
The syrinx expands and compresses the spinothalamic tract fibers that cross in the anterior commissure. Since these fibers carry pain and temperature sensation, their disruption causes the characteristic bilateral cape-like sensory loss.
Okay, here's a question. In Syringomyelia, which type of sensory function is typically spared?
The answer is fine touch and proprioception, because the dorsal columns remain unaffected.
Perfect. So what's our next case?
A patient is brought in after a severe car accident. He has loss of pain and temperature sensation below the injury level, as well as complete motor paralysis, but his vibration and proprioception remain intact.
This has to be anterior cord syndrome, where motor and pain temperature pathways are affected, but proprioception is spared.
Yup, anterior cord syndrome occurs due to ischemia or trauma affecting the anterior spinal cord, leading to bilateral paralysis and loss of pain and temperature sensation, while proprioception and fine touch are preserved.
And what causes this?
Common causes include spinal artery infarction, severe flexion injuries, and aortic pathology like an aneurysm dissection.
But why does proprioception remain intact?
Because the posterior columns are supplied by the posterior spinal arteries, which are unaffected in anterior cord syndrome.
Got it. And now let's do a quick recap for our listeners.
Alright, let's start with spinal muscular atrophy, genetic degeneration of anterior gray horn cells causing flaccid paralysis. Amyotrophic lateral sclerosis, ALS, and neurodegenerative disease affecting both upper and lower motor neurons. Tabes dorsalis, a late complication of syphilis causing dorsal column degeneration and sensory ataxia. Vitamin B12 deficiency leads to subacute combined degeneration affecting the dorsal columns and cortical spinal tracts. Cauda equina syndrome, a surgical emergency involving compression of the cauda equina nerve roots. Poliomyelitis, viral destruction of the anterior horn cells causing asymmetric flaccid paralysis. Friedreich's ataxia, a genetic condition with spinocerebellar tract and dorsal column degeneration. Brown-Séquard syndrome, spinal cord hemisection with ipsilateral motor loss and contralateral pain/temperature loss. Central cord syndrome, weakness predominantly in the upper limbs after hyperextension injuries. Syringomyelia, fluid-filled cyst disrupting pain and temperature sensation in a cape-like distribution. Anterior cord syndrome affects anterior motor and pain pathways.
And that wraps up today's episode of PodBites. We've covered a lot of ground on spinal cord and peripheral nerve disorders, from case-based discussions to diagnostic pearls and treatments.
We hope this helped simplify complex topics into digestible bites. If you've enjoyed this episode, don't forget to follow us and share with your friends.
Until next time, keep learning, stay curious, and we'll catch you in the next episode of PodBites. Take care!